All right. So thanks so much. So today we'll be talking about CAR T, and thanks to Dr. Baluj and Gabe for making it all the way out here from the north side. And since that's our experts, that's who will help guide us throughout. So I think, as with anything, it's really important to kind of know the background and the history of to how we got to this point. And if you really look at the cancer kind of timeline, it's pretty incredible that really from like 1880s, really, when we started, to fast forward really 150 years that we've come to CAR T. So what really has helped surgery in general was the advent of general anesthesia. That was kind of like a major marker. And then the first things that we really started doing for any kind of cancers are Johns Hopkins is kind of the forefathers of medicine, Homestead, those kind of guys, and they started doing radical mastectomies. And that's kind of where the advent of our approach to cancer began. The second thing which kind of surprised me was actually radiation therapy started shortly thereafter in the early 1900s. And then really you fast forward almost 40 years when you have NCI, and then finally in 1947, using the first approved chemotherapy, which was nitrogen mustard, which is also what they used in war, was used to cure pediatric leukemia. So that's where we kind of picked up our theory of using chemotherapy, where we're using chemotherapy to kill the most rapidly dividing cells. And when we use that, we also cause all the adverse effects that we see in chemotherapy, systemic chemotherapy, because the other rapidly dividing cells you're going to see are your T cell, like your bone marrow, your GI, and things like that. So I'm sure if you're looking at the cytotoxic effects of a lot of those chemotherapies, that's where you're going to be. So that's the first chemotherapy that was approved in the United States in 1949. In the 1900s, so 100 years, really we've made a lot of headway. So the first thing that kind of changed the game is the BCR-ABL that we all have to know, and Gleevec, and in 1960 they discovered the Philadelphia chromosome. In 1965 they started using chemotherapy for Hodgkin's lymphoma, which was also another kind of big change in things. And then the other thing that's changed the game, as you guys can all appreciate now, that we take probably for granted, is in 1974 we started using CT scans to kind of monitor things. In 1986 we started using tamoxifen, so that's when we kind of discovered receptor therapies and things like that, which is, again, a change in kind of our thinking, is that there's, if you look at the Philadelphia chromosome and tamoxifen, we're starting to look for receptors, so our technology is improving and things like that. 1989 is GCSF, and then basically 1884 to 1991, so 100 years it took us to start decreasing death rates from cancer. So that's pretty impressive that we're able to do that in 100 years. The other kind of big marker, if you look at things in the big picture, are rituximab. So rituximab is the first monoclonal antibody approved, and what that did was target the B cell, specifically in a B cell receptor. So that was kind of how we were thinking about it. And then Herceptin, or trastuzumab, was targeting HER2 receptors. Again, a new kind of therapy in that time. And at that time, if you were diagnosed with that cancer, with a HER2 positive cancer, which there were 25% of cancers, there was no effective treatment. So that is a major kind of breakthrough through discovering the HER2 receptors. And now we use that actually in GI cancers and stomach cancers, things like that. So 2000s, we move on, and the Gleevec is approved, and I think that trial was actually stopped short because of improved efficacy. And then in 2003 is a major marker, and I never appreciated, I think we all know that the human genome was decoded at that point, but the knowledge we probably gained from that is massive, because the same year we discovered that the EGFR gene, which we now use to target a lot of therapies in lung cancer. The next kind of thing, so then that's the 2000. So the next kind of wave of things is using basically blocking the angiogenesis. So that's Avastin, that was a major breakthrough. In 2010, there is basically, 300 million people in the US, so 14 million people are cancer survivors. And then in 2013, we started to kind of introduce our topic, which is CAR T. In 2015, we're seeing more and more immunomodulators that are direct. So I think we've all seen like Pembro, Atezolizumab, Nivolumab, and we're seeing a lot of those. So our ability to inhibit replication of cancer cells and things like that has been increasing, but it's also immunosuppressive, and I think that's kind of what we'll be coming in. And then 2017, CAR T has been approved for more therapies, and we'll talk about that. So if you look at it just as a big picture kind of view, we've gone from basically only surgery, that was the only option. Fast forward basically 40 years radiation, another 40 years chemotherapy, 100 years to immunotherapy and gene therapy. And I think that's kind of where the next wave of what we're looking at and what our generation will see is we're discovering the receptors, and then we're designing drugs to pinpoint those receptors to help with cancer therapy and targeting, at also the price that we will have to kind of balance, and that's immunomodulation and more immunocompromised. So CAR T stands for Chimeric Antigen Receptor T cells. So what does that really mean? What all those fancy words really mean is we take our T cells from our patient, we infuse it, and we give them new receptors to kill cancer cells. Because our own innate T cells help to control cancer cells, and we use those receptors to kill. The thing that CAR T does, though, the other thing to just make sure you note, is it brings on one receptor, one type, and it's very specific. So it can target only specific things. So I think that's a big kind of differentiation. But we're using our own cells, which is probably the most efficient way of killing. And I think that's kind of why we're going to see a lot of the side effects and everything that we see. And then I borrowed this slide from a previous presentation about CAR T from our BMT folks. The next kind of big thing in CAR T is that there has been multiple generations of CAR T. The 2007, when everything was kind of getting generated, the first generation of CAR T cells were slightly different. And the biggest difference between now and then is that these second generation CAR T cells that we're using now have an extra tag on it, and that's CD28. And what that does is it helps the receptor that we express for the CAR T cells to bind and create more immunomodulation and stay more active and replicate more. So that's really important. The other big question I had, and I was trying to figure out, and it was really hard to find, actually, I asked Dr. Baluch, and I was trying to figure out, is how are they getting the cells to express these genes or these receptors? And that the way they do it is they use a lentivirus to introduce it. And we'll talk about all the specifics. But what lentivirus do you guys know? HIV. So what they do is they quote-unquote disarmed HIV, and they're using HIV to incorporate into the genome and express this receptors. Now, what does it mean to you that they disarm HIV? What would that mean to you? Like, how do we disarm? What does that mean? Because that's what I was confused about. So what that really means is that they took out the mechanism for the HIV to replicate, but they're using the lentivirus. So I think that's an important point because we just don't have much data ongoing, so we'll kind of see. But just food for thought. So how do they do this? How do they take the T? So they'll basically, I'll show you another slide about it, but basically they pherese all the T cells out of the patient, and then they send it to a company or a site. And what they do is they take those cells, they package that with the lentivirus together, and then that lentivirus will incorporate its DNA, and then it will express the receptors, and then it will start replicating. And then the second generation ones are better at doing that, essentially. What does it look like? So basically, it looks like our normal T cell, and then you see the antibodies going there. And then this right here, number 5, if you look, that's kind of the biggest change that they have done. So they're expressing that antibody. And then number 1 is the targeting domain. So that's kind of the receptor that is going to target a specific site. So in the way that we use it right now, it's used in ALL, CLL, and lymphomas, is that it targets CD19. And again, that's really important because in this lymphomas, you have one target and one problem, one solution. So it's going to work very, very well in that situation because it's like a pistol, like you have one target. So what's the difference, right? So the big difference is if you have a CD4 cell or a T cell in general, it needs to use like MHC to reconfigure and bind, and then it'll make all the recognitions, and then it will start working. What this does is, you have like direct C antigen, bind the receptor, and cause apoptosis. So that's why it works so well, because it doesn't need any of those like antigen, like dendritic cells to present the antigen. You make the antibodies, you kind of bind and kill, but because it has everything kind of ready to go and cause apoptosis much faster and with much less kind of binding. So that's why it's really effective. So what does this look like kind of like in a big picture view? So you have a patient who can be inpatient or outpatient, and what they'll do several weeks before is that, and you have to have a certain, I don't know the criteria, but a certain amount of lymphocytes. They'll apheresis that out. They'll send that off. And then they're going to use kind of what we talked about, express the cells, and then they will send the product back. The patient will get more chemotherapy, specifically lymphodepleting therapy. So they'll get more chemotherapy, and then you'll infuse the CAR T cells. That's usually been done inpatient, but I think in the broad spectrum of things, we'll kind of see how that goes. But, and that day of infusion is day 0. And I think that's also kind of just important to note. So then, again, they're going to get the lymphodepleting therapy in or outpatient. And right now, there's little data, and we'll talk about that, about what to do. So you're getting a lot of chemotherapy. You're going to be neutropenic, although not expected to be prolonged. So then we kind of guess at a prophylaxis once again. And it's kind of usually they'll on day 0 start acyclovir, ciprofloxacin, and fluconazole. Unless, as always, in infectious disease, it depends. Unless you have a prolonged neutropenia history, and you're already neutropenic and you're going to be prolonged neutropenia, or you've had like invasive fungal sinusitis, or you've had ALL with several relapses, and then you've gotten multiple lines of chemotherapy, and you need to have a different prophy regimen, things like that. But typically, that's the regimen we use, and that's the regimen that we use at Moffitt. And then the paper we'll discuss that has a lot of data is the same regimen that they were using at Washington University in Seattle. So right now, there are 2 major types of CAR T cells. So the first one is SCARTA, and that we can use for diffuse large B-cell lymphoma after failing 2 sides of systemic chemotherapy. There are some trials at Moffitt ongoing about using that as first line as well. And then the second one, the Chimeric, is going to prove more for ALL as a precursor, as a first line, and then again for diffuse large B-cell lymphoma. And because at Moffitt, they mostly treat people over 25, we mostly see the diffuse large B-cell lymphoma rather than the ALL. There's some ALL still, but that's why I kind of focused more on the diffuse large B-cell lymphoma. So prophylaxis, because that's a lot of our consults, we try to find some guidelines, and supposedly they were supposed to come out, maybe soon, hopefully they'll come out, but you look at, but NCCN doesn't have any formal guidelines, and I think some of this is site-specific, although I think we do a lot of the same things that they're doing in other places. So again, the day 0, and then, which is going to be usually ciprofluconazole acyclovir, and then day 30, they'll start PCP prophylaxis, so either Bacterium Receptor or an equivalent, just depending on the situation, like if you need to engraft your counts or something like that. So then the other biggest thing, when you're talking about an excellent therapy, is what are the toxicities or side effects, because nothing is free. So there's pretty recent guidelines about how to deal with the toxicities that were published in February of 2019 in NCCN, so we'll talk about those. But the really big things that I focused on and I think are kind of most common and most important are CRS, which is cytokine release syndrome, and then different from cytokine storm. So I think that's kind of what we have to ensure we're not confusing with. And then the neurotoxicity. And then lastly, we'll talk about kind of what everybody is, I think, here most interested in is that's a review of the infectious complications. And quite honestly, there's just not that much data on it yet because this is still something that's pretty new. So the first thing is what we call cytokine release syndrome. So as you guys saw in the kind of slides, that your receptor is going to bind, and you're going to make massive amounts of inflammation. Because of that, the recommendation are at least to check 3 times a week ferritin and CRPs. Your CRP, just as I know, is made in the liver. And then if you have more disease burden, you're going to have more inflammation. So you're higher risk of CRS if you have more disease, which just kind of makes sense. And then the numbers of how much CRS do most people get vary. So the trials, there's 2 main trials, the Juliet and the Zuma trial, and one of them was 58%, and one of them was 23%, but regardless, a pretty high number. You're going to see it if you're high risk of seeing it. And the reason I mention this is the symptoms are something that ID is going to be involved in, and that's because they're having fevers. And not fevers to like 100.4, they're having like 104, I mean, really high fevers. You can have myalgias, hypotension, which again, you have fever and hypotension, tachycardia, that's easily confused with sepsis. And then some myalgias. A lot of organ involvement. You can have kidney damage, liver damage, GIC, and things like that. We'll talk about neurotoxicity as well. You can have cardiomyopathies. I mean, if your lymphoma can involve it, and your inflammation can involve it, your CAR-T can involve it. And then what they're seeing also is elevated CRP, ferritins, and then the interleukin markers are also going to be really high. This slide is more for your reference, and this is how they treat it from NCCN. But I think really I wanted to have this as a reference for you guys. But what they do is they grade the degree of CRS. So if you're having a really high fever, just fever, plus minus a little tiny bit of hypotension, you can support them with fluids, unless it's persisting more than 3 days. If it's persisting more than 3 days, that kind of goes to grade 2. And then you're going to be talking about getting tocilizumab, or TOSI, which is an IL-6 inhibitor. And from reading about it, they're not sure exactly how it works per se yet, and you guys can correct me if I'm wrong, but they don't know how it works, but it blocks it and it helps with CRS, unless you guys know. Okay. The other important thing with that is, and then you kind of go down the pathway. So if you're having fever, hypotension, you're needing pressors, then that goes to grade 3, and then multiple vasopressors and needing BiPAP, CPAP, ventilator support, you're going to grade 4. The other important thing is, so at grade 2 you use TOSI, but then as you go further, you're starting to use dexamethasone. The reason it's important to realize about dexamethasone is because if you're using it more than 14 days, then you're risking the destruction of the T cells. So they definitely want to limit it, but it's a fine line again between immunomodulation and the cancer therapy, kind of like what we're always dealing with. The other thing that's important is that this typically develops within 2 to 3 days of infusion of CAR T cells. And then it's not as fast as an onset. So I think that's a major differentiation syndrome between cytokine storm. Cytokine storm, somebody comes in super septic, they're like crashing, dying, as opposed to this is more insidious. So I think that's kind of helps us think about it. But again, these patients are so high risk. They've gone through multiple lines of chemotherapy. They're profoundly neutropenic. They're chronically neutropenic. So kind of take everything as per patient kind of case scenario. So go ahead.
Sorry. So only grade 1 empiric broad spectrum?
Oh, sorry. You go broad spectrum throughout. Additional.
Oh, okay.
Sorry, yeah. You go throughout. You go broad spectrum the whole time. And then the thing with the broad spectrum, I was just talking to Dr. Belushi about this today, is that how do you know when to peel back? I think in BMT, usually we'll say 5 days, or 40, it just depending, but usually in 5 days you can de-escalate if everything is negative with the new data that we have. But in CAR T, I think we're going more towards 7, and it just depends because it's so hard to tell what's kind of going on with what. You can say something. Okay, talk then. Okay. But it's, again, I think it's case by case. It's hard to. I don't know that you can generalize this just yet. So the next kind of big category, and I think a lot of, if you've been on BMT, kind of seen this, is there's neurotoxicity involved with CAR T. And the biggest kind of ways that it presents is almost like a delirium picture. The patients have more like trouble word finding, aphasias, they're having writing difficulties, and up to seizures. We don't know the exact pathophysiology of it. I think some people speculate maybe you have CNS involvement and things like that, but there's not definitive. But we think it's either the cytokines, kind of the inflammatory reaction, or maybe the CAR T invasion. And the other thing that at least they do at Moffitt is usually before they even start CAR T is they'll see neuro, and then they'll start them on Keppra whenever they're going to get CAR T, and they continue that for I think a month or two after, 3 months after. No, sorry, 30 days after. But they do put them on Keppra prophylactically. And then the other kind of just more of a resource, just so you guys know that it's there, is there's also the ICE kind of score that they will test them every day, and you'll have orientation questions, you'll draw, you'll write, and things like that. What they'll do, and then they'll grade that, and based on that will be kind of the way that you manage whether you think that there need to get different therapies. But they're all in prophylactic Keppra. The kind of, this is more kind of the treatment of it. So if you're just grade 1, where you're scoring kind of more like in the 7 to 9 range, they're just going to support them through it. But if you're progressing and your scoring kind of decreases, at that point they'll usually start them on dexamethasone pretty rapidly. But again, you want a limited duration, and you just have to kind of be careful. But ultimately, if you're having persistent seizures, you're going to have to do kind of what you have to do, as well as TOSI. And then this slide, I didn't talk about a couple of the other syndromes, but these patients are also a risk for HLH. And then the last, as well as they're noticing that there is a lot of hypogammaglobulinemias, whether that's the CAR T cells or just the multiple lines of chemotherapy. But you are at risk for it, so they'll change immunoglobulins, and you have to get repletion, or if you're getting certain infections, they'll kind of boost you through it. So the infectious kind of complications in there. So there's limited data. There's one study from that was published in 2018 from Seattle that describes their experience. The N is relatively small. I'll show you all the numbers and things. But I think my takeaway is, what does this really mean for our patients? I think we can infer and kind of guess better maybe in some things, but if the patient populations are markedly different, like we're seeing only or mostly diffuse large B-cell lymphoma, that could mean different things for us. And then I think, like everything in infectious disease, it depends, because, as Dr. Tony would say, kind of had it once, got it again kind of situation. That's kind of like your biggest risk factor. If your patient comes in and has had infection, I was hoping he was going to be here, but if your patient had invasive fungal sinusitis or a mold pneumonia, yeah, that's what you're going to be worried about, or CMV colitis or something like that. You're not going to be worried about some other things. The infection data, this is the overall cases, and at the top what you see is that any infection, be it viral, fungal, or bacterial, is about 23%. Bacterial infections were most common at 17%, and then next viral infections at 9%, and then fungal infections at 4%. Notably, all of these patients were on the prophylaxis that we talked about, acyclovir, Cipro, and fluconazole. They continue that typically for about 3 months or until ANC recovery, and they were also on Bactrim. They also give them IVIG if their IgG levels less than 400. So they kind of standardize that. But there were 43 infections in 30 of 133 patients. So if that makes sense. So 30 out of 133 had infections, but there were 43 infections. So that means that out of those 30, at least 13 had, some kind of variety of multiple infections in several patients. But overall, it was 23%. So if you look at the infections by malignancy, I think that was kind of an important slide for us, because if you look, they had a lot of ALL. Or the other thing I want to point out is they broke it down between 0 to 28 and 29 to 90 days. It's important for 2 reasons. Number one, 28 days, you have more infections, which kind of makes sense because you're most immunosuppressed. But we only have data up to 90 days. So we don't know what will happen after 90 days. So I think that's a limitation of just the data that we have and need for future kind of reference and kind of seeing what it's going to have. They classified the infections by mild, moderate, or severe, or life-threatening. But the overall numbers, the highest were ALL and non-Hodgkin's lymphoma, and then CLL the least, which is, I don't think that's surprising. And again, most of the infections were less than 28 days, and most were severe. The type of infections we'll kind of break down step by step. So there were 133 total patients. There were 62 non-Hodgkin's lymphoma, which kind of I think is what I focused on the most. And then if you looked at bacterial infections, that was kind of the most common at 17%. But it was less common if you look at the non-Hodgkin's lymphoma. Most of those were ALL. The most common, bacterial infection was kind of more soft tissue, but a lot of bacteremias, 8% bacteremias. Viral infections most commonly were respiratory viral infections, and we'll break that down a little further. And then fungal infections were mostly non-mold, but a couple of mold infections, and we'll talk about what I think that kind of happened. So if you look at the bacterial infections, most of them were coagulated staph, streps, and enterococcus. So I think that probably leads to more like line infections and the bacteremias from everything. The second most common was gram-negative, so that's presumably from either GI sources or things like that. But a couple of E. coli's, but several that I don't know that I would have expected, like Acinetobacter, Steno, which means they've been getting a lot of antibiotics, Captosinophagia, which was interesting, and Mycoplasma. So I think some of those things I didn't necessarily expect. I think the gram-positives are kind of expected, but the gram-negative distribution was, I think, just interesting, especially with some of the resistant stuff. They saw 5 cases of C. diff, and then a couple of pneumonias, 3 soft skin tissues, 3 UTIs, and 1 parasinus. The viruses, I think, were interesting because I think that's what we look for a lot when we kind of see these patients, because we'll get the HHV6, EBV, CMV. They only saw one CMV and one EBV, and then a lot of URIs, mostly rhino, which is, again, that's not unsurprising, rhinoentero and paraflu, and then 2 paraflu pneumonias, or lower respiratory tract infections. So I think that was interesting, too, that not as much CMV, EBV as I thought would be there. And then fungal and mold, I think, was kind of difficult to interpret. The fungemias, I think, are like a slam dunk. Fungemia is fungemia, but I think there were a couple of candida pneumonias, which, you know, is interesting. And then 2 mold infections, and again, 4% of infections in general. So what they did, I think was really important, is they broke it down of who is at highest risk. And then I think those findings are not too unsurprising. So if you're profoundly, chronically neutropenic, you're at highest risk. I think that intuitively makes sense. Because that's the patients we most worry about. The next was interesting, and I think it makes sense, but I'm glad that we're able to prove this, that if you've gotten multiple lines of chemotherapy, so you know your T cells and immune system is not normal anymore, you're getting multiple lines of chemotherapy, and then CAR T is kind of your next line, so you're at higher risk of infection. If you had more CAR T infusion density, but that meant that you had more disease, usually I think, so that puts you at higher risk because then you can have more CRS and things like that. So what does that really mean? I think that it means that we can classify when we see these patients and knowing that they'll be at highest risk. But then the question is, do you change the prophylaxis? I think that kind of would arise. And I think, again, that's a case by case. And like we talked about before, if you're profoundly neutropenic for a long time, maybe you do need the mold coverage. So I think that's something that's still kind of up for debate. So, sorry, go ahead.
CAR T infusion densities, is that something that's measured, or?
I think that's how much. Yes, that's how much they know how much they give you.
Oh, okay.
And it correlates with how much disease you had.
Mm-hmm. Usually, I think disease, but then you're at higher risk of infection, which kind of I think makes sense.
So of the infections that the patient had in the series,
Mm-hmm.
is it more newly acquired infection or reactivation?
They didn't comment on reactivations, but if you look at,
A recurrent infection of what?
they didn't comment if they've had it before. I think that was, they didn't say if they've had that infection before in the article. But I think, yeah, like for the, like if you've had, like did this patient, where is it? Did the patient who had invasive fungal sinusitis have invasive fungal sinusitis? It doesn't comment on that, but you would think that that patient was at higher risk, be it by the prolonged neutropenia or something like that. But it doesn't comment on that patient specific. Does that make sense?
The other thing is, like, for example, Aspergillus eustace is known for the, once you select out and you kill the Aspergillus fumigatus and flavus, that eustace is often right behind it. So it's known, especially in the SOT field, as having, these are people that are highly exposed to triazoles already.
So probably maybe may have had fungal sinus
More
more.
lines of therapy, and that each time you've been on a line of therapy, you become neutropenic.
Selected out, yeah.
Each time you've been neutropenic, you've been exposed to cipralevo, maybe some fluconazole, maybe some ampho. You're going to select out then a fluoroquinolone resistant gram-negative
right.
rod. Then you're going to select out a Vori resistant fungus. This is why you've got glabrata instead of just albicans, because these are bugs reflective of multiple lines of therapy. And with the Stenotrophomonas, honestly, this is again reflective of antimicrobial stewardship pressure over longitudinal, over the life of the patient.
Right.
You know? And I mean, the statistical likelihood is that these are mainly translocations from the GI tract, whether they're strep from the mouth or gram-negative rods from the GI tract. You also don't even know what's the microbiome for that particular hospital.
Sure.
There are a lot of hospitals that have much more Centobacter, like TGH, compared to Moffitt. We just have a different set of bugs.
Right. And that's why I think that was the caveat in the study is we don't know how that patient population reflects to our patient population because their flora is going to be different from being a Moffitt patient as opposed to a Washington, Seattle patient, just by virtue of their locations and their flora from the hospital, because they're getting all this chemo from the hospitals. So we talked about the highest risk. Okay, so the take-home points, really, I think, if you look at the big picture, out of all those patients, about a quarter risk of infection. So most of the complications are not infections, right? If we looked at the Juliet and Zuma trials, 58 to 23% had CRS. So in the neurotoxicity rates, those are going to be kind of what we're most concerning. But if they're going to get an infection, most commonly is in 28 days. We don't really have much data later on. And then, what will happen a year from now? And I think that'll be interesting to see because I just don't think we know yet. And then kind of the big thing was at Moffitt, particularly what we've been seeing is more diffuse large B-cell lymphoma, although there's still some ALL, kind of what you're working on. And then there's trials about CAR T being first line of therapy, which would change the game, I think. And then there's many factors what puts you at risk for these infections. Getting 4 lines of chemotherapy, having invasive fungal, or having those other things can predispose you to reactivate, like Dr. Samoon was saying, or you've kind of suppressed it, kept it at bay, but when they get additional chemotherapy and CAR T, you're allowing it to kind of proliferate. So thank you for Gabe and Dr. Baluch for coming and helping, and the BMT nurse practitioners and PAs, and we'll take some more questions.